Okay, so let's move on. So we're going to go over the baseline characteristics. We're going to take a look at the key efficacy signals as well as safety signals, and then the effect on quality of life. All right, so here's the table of the baseline characteristics. And you may notice when you're looking across the cohorts that the numbers are not the same. And so this was an open enrollment study. So we took patients as they came, no matter which cohort they would ultimately fall into within the construct of the trial. And you'll notice that cohort 3B has significantly more patients than the other groups. And that's because towards the end of the study, the cohort 1s, 3A, 2 were all close to enrollment. And we expanded cohort 3B to get a better sense of how luspatercept performed within that population. Okay, cohort that included patients on ruxolitinib and were transfusion dependent. And a total of 95 patients were enrolled on the study. About half the patients, a little over half the patients, had primary myelofibrosis, and the remainder had post-ET or post-PV myelofibrosis. The time since initial diagnosis to being screened was pretty decently long, and the average time of ruxolitinib prior to study entry was also significantly long. So, quite a range of ruxolitinib exposure there. This did include patients with intermediate 1, intermediate 2, and high risk disease. The majority of patients, though, had intermediate 2 risk disease by the DIPS scoring system. And I think the kind of key piece here is the transfusion burden upon entry of the study. So this is going to be cohort 2 and cohort 3B, transfusion dependent off Rux and on Rux, but a significant number of transfusions. So half the patients were getting 6 to 12 units every 84 days. So that's a lot of transfusions. And so you can think about that as a burden to the patients, having to come in, get their type and screen, sit there for the transfusions, once a week, twice a week, as well as on the hospital system, right? So blood is a scarce resource, and we're often having to allocate blood resources across several services within our hospitals. And so I think that's a really important point to make. The transfusion burdens is pretty significant with these patients. So treatment exposure. So for the overall group, the median treatment duration was 24 weeks, and the range there from 2 to 85 weeks. In those receiving ruxolitinib who were transfusion dependent, it also was 24 weeks, ranging up to 82. So really quite a few doses were given on the clinical trial, and patients did maintain therapy for some time. I think the key point for me in this table is the dose escalations. So the way the drug is administered, it starts at 1 milligram per kilogram with options to escalate to response. And a vast majority of patients do need a higher dose. So 86% of patients got up to the 1.33 milligram per kilogram dose. And actually a significant number of patients also had to get up to the 1.75 milligram per kilogram dose. So really the key is when using luspatercept in the aspect of this clinical trial or outside of this clinical trial, kind of ramping up that dose to get response was a key piece. The percentage of patients on the time of data cutoff is shown here as well. So in the overall group, 19 patients, which is a quarter of the patients were still on active treatment at the time of data cutoff. And the average Rux daily dose. So this, again, Rux is given twice daily, but if you add that together, you can get the daily dosing. So in those receiving ruxolitinib but not transfusion dependent, it was 20 milligrams per day. And it was the same average dosing for those receiving regular transfusion. So kind of a middle of the road dosing for ruxolitinib on average. And again, for those who were on ruxolitinib, the dosing did remain stable throughout the 24-week assessment period for those two cohorts, because altering the Rux dose could potentially influence the anemia responses. So here are the key efficacy endpoints for the study. Left is the primary treatment period, so those first 24 weeks, and then the right set of figures is the entire treatment period, so the entire duration of the study. And it's broken down by the different cohorts, the cohort 1 and 3A, the non-transfusion dependent groups, as well as the transfusion dependent groups, cohort 2 and 3B. And we can see the percent of patients who met the primary endpoints shown here on the left, in yellow. So this is kind of the strict endpoint of being either a 1.5 grams increase for 12 weeks or transfusion independent for 12 weeks, depending on which cohorts they're in. And we can see that cohort 3B had the highest number of responses by those stringent criteria of roughly 26.3% of patients. So a fair number of patients meeting that kind of very stringent response in that group. But we definitely saw responses across the board. The challenge with that is, again, this bar is very high and a very stringent anemia response. For example, if a patient were having a response and then had appendicitis and had surgery to remove their appendix and then needed a transfusion within the context of that appendicitis and an appendectomy, they would no longer be a responder. And so as we kind of got into the data, we saw several instances of this. Something would happen that led to a transfusion or a hemoglobin drop, an infection, or things like that. And we lost a fair number of responses. So we also looked at these kind of softer, more practical or pragmatic responses, and I think more reflective of truly the benefit of this medication in these populations as the secondary endpoints. So averages increase of 1.5 grams from baseline, or at least a 50% reduction in the red cell transfusion burden from baseline. So in the cohort 3B, half the patients had at least a 50% reduction in their transfusion burden, which I would say is a clinically significant endpoint. I think that would be meaningful for a patient. And so you can see the kind of broader benefit, both in the primary treatment period as well as the entire treatment period for those patients. So here's a little bit more kind of granular data. Median time to anemia response was relatively quick for these patients, a month. A little over a month, you're seeing responses. In some patients, anecdotally, we see responses as soon as a week. But on average, it takes about a month to see the anemia response. And the longest duration of anemia response in days for cohort B3 was 534 days, as well as for cohort 2, the other transfusion-dependent cohort, was 623 days. It was shorter, albeit in fewer patients. For cohort 3A, it was 85 days. And for cohort 1, those are no rux but anemic, it was 457. So the responses, particularly those who were transfusion dependent, was quite durable. And in the bottom row, just to kind of focus in on some of the symptom improvements. So some patients were having significant symptom improvements, albeit a small amount of patients, as measured by the NPN SAF TSS score. So that is a valid way of measuring symptom burden in patients with myelofibrosis. All right, so kind of went through that quickly, but I'm trying to keep mindful of our time here. But patients who were transfusion dependent and treated with ruxolitinib, that's cohort 3B that we really focused in on, experienced the greatest numbers of patients who had anemia responses, certainly by that strict criteria of a 12-week transfusion independent period. Cohort 3B also had the highest percent of patients who experienced at least a 50% reduction in the red cell transfusion burden compared to cohort 2. Cohort 3A, who were not transfusion dependent but treated with ruxolitinib, had the highest percent of patients with an average hemoglobin increase. Patients who were transfusion dependent and treated who were not on ruxolitinib experienced the shortest median time to anemia responses. And patients from cohort 2 also experienced the longest mean duration of anemia response. So again, I think the key take-home point here is it can improve anemia and reduce transfusion dependency. May not eliminate transfusion dependency in all patients, but a large number of patients will have at least a significant reduction in the number of transfusions they're getting. Of course, the other side of the coin, we always want to look at adverse events. And really, kind of as we saw with the studies done in myelodysplastic syndromes and thalassemia, the most common side effects included hypertension. So that was seen in almost 18% of patients. Bone pain, particularly in the days after injection, as well as diarrhea, which was seen in about 6% of patients in total. The hypertension in most patients was easily controlled with an introduction of antihypertensive. The bone pains were often treated with antihistamines. And the diarrhea was treated with medications like Imodium to slow down the diarrhea effect. There were also other rare side effects that were reported, but no true pattern of incidence was seen over and over again in this adverse events table. But I think the key take-home point from this is the side effect profile, very similar to other studies that have been done with luspatercept in different populations. No new safety signals emerged. And looking at the side effect profile, the thing that really jumps out to me is that the opportunity to combine with other medications. There won't be a lot of overlap, say with JAK inhibitors or BET inhibitors or BCL2 inhibitors, any of these other medications that we're developing in myelofibrosis. So, taking a look at this, it would play well with others in the sandbox. So just to summarize this, patients who were not treated with ruxolitinib in cohort 1 had the highest percent of patients who experienced at least a treatment-related adverse event, but really the vascular being hypertension, musculoskeletal being bone pain, and GI being diarrhea were the most common treatment-related emergent events, adverse events, but all occurring at low frequencies. So kind of getting into Katrique, what's missing, getting critical about the study here, what's missing in this study, and where can we kind of go from here with this? Certainly the strengths is, it was a broad-based study. We included lots of different types of patients with myelofibrosis who were on and off treatments. And I think that gives us a clue in multiple different populations how effective or lack of efficacy as well of this medication. The patients on ruxolitinib had to be, it was a very narrow selection. They had to be on a very stable dose for quite some time. And I think in the real world, those patients are difficult to find. Generally when a patient is on ruxolitinib and they become anemic, the dose is adjusted quite regularly, up and down, as the counts kind of settle out. And so that doesn't really happen in real life. And having someone on such a stable dose for such a long time, but yet still being anemic is kind of a rare thing. So I think that's definitely a challenge in applying these results broadly. I think the key lack of what we have here are biomarkers predicting response. Clearly, patients were responding, but what predicts those response, we don't really know. The best biomarker we have, honestly, is the fact that the patients on Rux getting transfusions had the largest number of responses, and that's the best biomarker we have at this moment. We're digging into this data more, looking at things like ferritin or hepcidin or iron stores. I think we really want to try to dig deeper in these kind of samples that we have banked from this study to try to find a biomarker that will predict response and refine our approach. There is the ongoing independent study, which is enrolling patients, primarily those cohort 3B patients. So patients on ruxolitinib who are transfusion dependent. It is enrolling patients, albeit at a modest pace. I think the challenge, as I mentioned earlier, is the fact that patients need to be on a stable dose of ruxolitinib yet be transfusion dependent, which is a tough thing to find and tough thing to do. Of course, we have other agents being developed that attack anemia with using different mechanism actions, and being trained hematologists and oncologists, we like to put things together. We like to do combination therapies, and so it makes sense to really tackle anemia in a broad sense and really kind of push those response numbers, combining it with active ACVR1 inhibition or other types of ways of attacking hemojuvelin and other ways of attacking the different facets of anemia. Because in any one given patient, anemia is multifactorial. It's due to a chronic inflammation, due to different impairment in shuttling of iron stores, blocks on late differentiation of erythroid progenitors, as well as these effects of our treatments like JAK inhibitors. So if we can if it's a multifaceted reason for this burden on these patients, it would make sense to take a multifaceted treatment approach. So certainly combination therapy, in my mind, is the next step for development of this medication.